we are going to talk about how to deliver a feedback, so communicating an autism diagnosis to parents. Next slide. So our learning objectives for today, so we're going to develop a framework for delivering an autism diagnosis. I hope that everybody can incorporate an autism feedback into their clinical practice, and then establish competence in answering parent questions. One thing to always remember is that parents will never forget the feedback session. So as many of you are getting trained in the STAT and will be doing, several assessments and evaluations in the future, you'll also be doing several feedbacks. Parents will never forget the feedback that you deliver to them. So it's important to do a good job at it. It takes time, it takes practice. All right, next slide. Regardless of the style, right, there are two key components of successful feedback. One is a personal connection with the family. So this is a feeling that the clinician genuinely cares about the family. Many of you will be testing your own patients, so you will have maybe already established rapport. Maybe you were there at the newborn visit. So it's really nice that you may already have that personal connection. For others, if you are accepting referrals from other providers, it's going to be more challenging maybe to develop that connection in one or two visits. But it's important to kind of develop your own style and be flexible. It's also important to be open and honest with parents. Next slide. So this is a general framework. You don't have to stick to this. This is what helps me kind of organize as I move into a feedback. In general, we start with a history and evaluation, and then prepare for the feedback. That's really important. Then how to begin a feedback, how to share the diagnosis, then reviewing the recommendations. And of course, it's really important to leave enough time for questions and follow up at the end. Next slide. So history and evaluation. So that starts from the very beginning, right? From the second they walk into your office and your front staff greets them, right? It's important to build rapport with the family and the child. Remember, parents are a big part of the visit, right? You're going to be asking them a lot of questions, right? That DSM, ADIR type interview is very much going to involve the parents. They're going to be doing questionnaires for you. So incorporate and make sure they are part of the visit. Ask them, I usually say, how can I help you? What brings you in today? What do you hope to learn about your child through this evaluation? Some families will present to your clinic and they won't even know why they're there. And so it's a good idea to kind of gauge, who told you to come here? What are you looking for? How can I help? I used to say things like, what are your concerns? And I've actually been corrected by some families. And they've said, I'm not concerned that my child has autism. I just want to know, right? So it's important to kind of think about the language that you're using. Determine the level of understanding that the parents have about why they're there, and even just the diagnosis of autism in general. And then I always ask parents, are the behaviors that we saw today, right? The communication we saw, the play that their child engaged in, is this typical for your child at home? Okay, next slide. Then preparing for the feedback is really important. So I always try to think about who is going to be in the feedback with me. What other family members are going to be there? Is it going to be mom and dad? Will there be an older sibling who's like running around and distracting, right? Are there medical students or other learners like pediatric residents in there with you? Will there be a therapist? Sometimes I have an early intervention or the infant toddler program, the speech therapist wants to come and observe and listen in. Will there be a patient care coordinator available? The patient themselves, do you have enough toys, right, available for the patient to keep them occupied while you're doing the feedback? Will you have an interpreter? Will they be in person? Will it be, a virtual interpreter, like an iPad interpreter? So these are types of things you kind of have to think about and navigate as you prepare for the feedback. What is in the room? So make sure you have tissues. There's been many times where I've had, families, in my office, and they go for a tissue and they get like the last one, and then there's none left, right? And so then I'm handing them like paper towels. It's embarrassing, right? So just make sure you have tissues on hand, toys for the child, and resources. If you're going to be giving a feedback, right, it's good to maybe have resources handy to kind of give to the family in the moment and kind of walk them through it. Where are you going to be doing the feedback? So is it in a private room? Are you doing it via telehealth? And how are your chairs positioned, right? It's always important to be, positioned towards the family. And when are you doing this? Timing is really important. Are you doing it first thing in the morning? Are you doing it, nearing lunchtime? Will the child be hungry? Is it nap time, right? So think about these things as you're creating your own schedules, right? And starting to do these evaluations and feedbacks. Okay, next slide. So how to begin the feedback. So I usually start by greeting the family, right? Thanking them for their participation and involvement. I usually summarize the assessment and developmental testing. And I usually start by saying, thank you so much for filling out all the questionnaires ahead of time, and thank you for answering all my questions. I know it's a lot for you to do, but I really appreciate it. Then we do testing, right? So today it looked like I was just playing with your child, right? And you guys are doing the stat, but really I was using a developmental assessment to look more closely at your child's development to see, where their development is at. Is there a diagnosis that, describes your child's development, and then come up with strategies, recommendations to help you guys moving forward. When I talk about all the information that we collect, right, sometimes I'll say, I only had 2 hours with your child, so I want to gather information from multiple different settings, right? So sometimes, I tell parents, I look at the physician referral or your doctor's note, parent-teacher questionnaires if they're available, the speech and OT evaluation, therapy notes, the IFSP. IFSP is the Individualized Family Service Plan that children have through the infant toddler program. Or if the child's a little bit older, like 3 years old, you could look at the IEP or the Individualized Education Plan from the Early Childhood Education Program. And then, of course, if there's any other standardized development testing that was done before, it's important to let the family know that you also reviewed that. Okay, next slide. Okay, so I like to review the reason for the referral. So summarize the family's primary question, and I try to repeat it word for word. I will even go back to my note now, say, at the beginning, you told me that your main concerns were communication, behavior, tantrums, sensory, right? Is there anything else that you want to add to that? I want to make sure that the parents feel like they've been heard, right? And they got everything out. There's nothing worse than saying your child has autism, and then they backtrack and say, but I didn't tell you this, right? What about this? What about this, and this, right? And so that is, that does happen. So it's important to make sure that they are able to express all of their questions. And then, like I said before, I review the evaluation process, like what we did, from the second they got the intake paperwork to, this point in time. Okay, next slide. Then sharing the diagnosis. So it's really important to monitor your nonverbal behavior. So make sure you are engaged, give eye contact as much as possible, right? It's hard, right? We're with electronic medical records, we're always trying to take notes and document and everything. So it's important to really engage with the parents. Offer hope and highlight the child's strength. I can't mention this enough. It's really easy, right? Angie did a stat today, and the child really didn't pass on any item, right? So sometimes it's hard to find those strengths, but it's really important for families. I try to highlight the best moment the child had. So maybe that was the bubbles, right, today, or maybe it was when the child requested the snack, or maybe when it was playing peekaboo, right? So really highlight where the child does best, where their joint attention is the strongest. Highlight areas of growth, right, in areas of maybe communication or sensory, and really, help the family understand their child and how best to support them. Next slide. Strength-based language. So here are some examples of, kind of deficit-based language on the left and strength-based language on the right. So we often use these terms like healthy or normal, but it's more strength-based use terms like typically developing or non-autistic. Okay, we're moving away from saying things like symptoms of autism and more towards like autistic traits or characteristics or features. Communication deficits could be more, communication differences. We used to use terms like obsessed with or, preoccupied with. Enthusiastic is kind of a better word maybe to use. Rigid with routines, maybe prefers consistency or insistence on sameness. Low functioning, and we'll talk a little bit about this at the end, but try to focus more on kind of benefits from a high level of support, right? And as I mentioned, highlight the behavior and communication strengths that you saw during the stats. Next slide. So be sensitive. I try to figure out where the family is at their understanding of autism and also their acceptance of their child's diagnosis, even before we do any testing. And so not every family will go through the grief cycle when they learn their child has autism. Some families are very happy, right? Because they're like, I knew this all along, and finally we can move forward, right? But it's sometimes helpful to look at this kind of chart and to try to figure out where the family is at, because that can kind of guide how you deliver the feedback. So for families who are maybe more in the denial and anger stage, the best thing to do is just to provide information and to communicate openly with them, okay? I really encourage you not to get into any kind of negotiating with parents at all or trying to prove the diagnosis if they are in the stage of denial and anger, but really just give them the information. For families who might be in the bargaining or kind of depression stage, emotional support is very helpful. And then those families who are in the acceptance stage, they're ready. They are ready for that roadmap. They're ready for that guide moving forward and taking those next steps. So, okay, next slide. So reviewing Dr. recommendations, I kind of just mentioned this. So create a roadmap for families. There is a lot. Elena has this great analogy of we kind of open up a fire hose at families and just like spray them with a ton of information, right, and recommendations. So it's important to know that that can be very overwhelming for them. So try to organize it as best as possible. Connect areas of differences to a plan, right? This is a team approach. So as a primary care provider, you guys are kind of at the center of it, right? You're kind of the quarterback, the medical home, but there are a lot of others who will be involved, and it's important to let families know that and to make sure that they are partnering with them. Provide resources and information, and discuss with the individuals who are there how they're going to share it with others. So some family, if there is a mother there and the father's at home, sometimes I'll ask the mom, how do you think dad's going to take this? Like, what are his thoughts and his opinions? And so that can be helpful. Sometimes I've given a feedback to a mom, and then I get a call from the dad the next day, right? And then I'm on the phone for like 30 minutes, kind of going over the diagnosis again. So it might be helpful to kind of gauge what other individuals in the family, how they might respond. Next slide. So winding down, so it's important to gauge understanding again, and give opportunities for questions, right? Prompt questions about different areas. I always say, any more questions? Is there anything else? Do you have any questions about his communication? Any questions about early childhood? Any questions about, behavior therapy, so that they can just make sure that they feel heard. And of course, touch on follow-up opportunities and schedule a follow-up visit if you are able to, or at least encourage the family to follow up with their primary care provider. Next slide. Okay, so autism diagnosis leaves families with a lot of questions. So these are my frequently asked parent questions that many of you will or already have received. So what causes autism? So I usually tell families there's no one cause of autism. We know specific causes of autism are currently unknown for the majority of individuals. However, it is multifactorial. So we do know that there are biological and environmental etiologies, and there are interactions, right, between genes and the environment and exposures that can increase the risk. There are several hundred genes. I mentioned this in a previous lecture. There are 700 genes that are associated with autism or increase a child's risk for developing autism. And so it's important to, again, when you discuss genetic testing with families, that you highlight that this is a possible way of finding out more. Okay, next slide. Why are so many children being diagnosed with autism now compared to years ago? Well, we have better monitoring, right? We have better diagnostic processes, so better assessment tools. There is definitely growing awareness and advocacy in the community. We're screening better, just in general. I think pediatricians are doing a much better job at screening. And of course, the diagnostic gap between white, Hispanic, and Black children has decreased significantly just in the past 5 to 10 years, which is great. So right now it's 1 in 36 children that have been identified with autism by the time they're 8 years old. Next slide. How do you know it's autism? His therapist thinks it's ... And I'm not picking on therapists. It could be teacher, it could be grandma, it could be anybody. But you will get this question. So everybody is learning through this program how to kind of map symptoms onto the DSM-5 criteria. So it's really great to kind of go over that with families if you have time, and you can. Review the standardized questionnaires with the family, like the SRS, as Angie said today. The SRS kind of matched exactly what the parents were saying. So, and it's a more standardized way of kind of reviewing parent responses. And then, of course, the stat results. Give specific examples and reference the parents' questions. We're going to be focusing on young children, right? So joint attention is something that you can discuss. In the first year of life, children will coordinate attention between a caregiver and an object of interest. Sometimes I will highlight, today when we were doing the bubbles, Sam was more engaged with you. He went over to you, he handed you the bubbles, he looked at you, and he made a vocalization, right? So find those moments where their child is more engaged in more joint attention, more eager, more social, right? To kind of make those connections. back and forth, right? So by 12 to 15 months, infants should have learned the value of people and the power of communication. So that's that reciprocity, right? I do something, you do something, that give and take that we've talked about before. Social referencing, a child will look towards parents and caregivers to check in. Sometimes that's important to just think about, even in that first assessment, when you guys are doing your interview, is to try to keep track, even just a little tally of how often the child checks in with their caregiver during that interview. And then functional communication. Communication should be spontaneous, it should be meaningful, it should be flexible, right? So these are just things to highlight with parents as to kind of why we think it's autism. Isn't he too young to be diagnosed with autism? He's only 2 years old. So we hear this a lot. So it's important to maybe, brushing up on the literature that's out there. This is a great study that was done in 2019. And it looked at what point the diagnosis of autism became stable. So the diagnostic stability. And what they found was that by 14 months, we are pretty confident the diagnostic coefficient, the stability coefficient, is about 80%. So there's an 80% chance that the child will not lose the diagnosis of autism when they are 3 years old. That stability coefficient increases dramatically as you get closer and closer to 3 years old, which is about the age period, right? Age time that we're seeing these kids and evaluating them. Okay, next slide. So this is, again, just more information about how children are being identified and how many more children are being identified by the age of 4 years. Okay, next slide. Okay, so this question I'm not getting as much anymore. He was a COVID baby. Are you sure he has autism? A lot of the kids that we'll be evaluating are going to be born 2021 or so. But what research has showed us is that there's no impaired neurodevelopment overall for children who were born during the pandemic. However, there was a slightly higher risk for children to have some communication delays, but overall social development should be typical. Okay, next slide. What level of autism does he have? Will this level change? So when we talk about levels, there's level 1, level 2, level 3, based on the DSM criteria. Level 1 is for children who require support. Level 2 requiring substantial support. Level 3 requiring very substantial support. Today, I think Angie presented a great case of a child who was level 3 in the area of social communication and level 3 in the area of restrictive and repetitive patterns of behavior. Some families will say, well, doesn't that just mean mild, moderate, and severe, right? And again, we try to be really strength-based, right? And so I, again, go back to the definition, right, in the DSM, and really it pertains to the level of support that we are hopeful the child will receive and that we are recommending for the child, okay? And this helps communicate to his therapist, to his teachers, to insurance companies, to anybody who works with the child, that this is a child who's going to benefit from a high level of support. Okay, next question, or next slide. Where does my child fall on the spectrum? And then, do you think I have autism? We'll talk about that one in a little bit. But so when we think about the autism spectrum, it's very broad, right? And families, a lot of people understand that now. And so it's important to let families know that try not to think of the spectrum as just a linear kind of line, but more as like a profile. So go to the next slide for me. And so it's more like this. Children with autism will have strengths and difficulties in different areas of development, and that will vary over time, right? So some areas the child will improve, in other areas they might lag behind, and then they might, make gains in certain areas over others. So it's important not to just have families focus on kind of that linear. It's easy to kind of conceptualize it that way, but it's more like a developmental profile. Next slide. Does autism go away? Okay, so autism is usually a lifelong diagnosis. This is what I tell families, but symptoms can improve over time and they become less apparent, okay? There are some studies that show children will outgrow the diagnosis. Go ahead to the next slide. And I try to quote these optimal outcome studies, okay? So children typically, I'll just jump to the middle there, children with higher cognitive functioning, higher language and motor skills, and verbal and motor imitation at a younger age usually have better outcomes. So these are the positive predictors of outcomes. Okay, next slide. I'm going to skip this. I know I have like 2 minutes left, so skip this, go to this. This is a great study. I quote this study all the time for parents. This came out in JAMA Pediatrics in, I believe it was November of last year, October of last year. And what this study showed was that some children improve so much when they get early intensive behavioral interventions, improve so much that they may no longer meet the full criteria for autism when they are school age, okay? The group that had the best outcomes were typically children who were assigned female at birth and children who had higher adaptive skills. Okay, next slide. Does my child need to be retested in the future? So I usually tell families that the school district, if they are going to be in an early childhood education program, they will test and monitor the child over time. So under the Individuals with Disabilities and Education Act, IDEA, this mandates that children between the ages of 3 and 21 with disabilities, they are provided a free and appropriate public education, okay? So they will determine eligibility for an early childhood education program. They will do an initial IEP process. So they'll open a domains. What that means is they will look at all domains of a child's development and learning, and they will determine if the child meets the eligibility for an IEP, okay? I'm going to jump around a little bit here, but once the child qualifies for an IEP, they will be reevaluated. They'll have a triennial review every 3 years. Will they assess the child, and then they'll write a whole new IEP. Now, when families ask about testing their child again privately, so I would consider a private evaluation for treatment planning, and I consulted with Dr. Harlan on this at kindergarten, 8 to 9 years old, high school, and for adult transition planning. So if there are challenges, if there are issues, I think these are critical time points that might be helpful in giving us more information and guiding how we help and support the child. Next slide. Will my child be normal? Will he learn to talk? Will he learn how to read? Will he be in a regular classroom? Will he graduate high school? Will he live independently? These questions will all come up. It is incredibly difficult to predict how fast a child will make progress and how and when, right? And so the will my child talk is a very common question. Jamie mentioned kind of pre-linguistic skills today, or precursors to language. So I like to highlight that because most of the children you guys will be seeing will be non-speaking, right? And so it's important to highlight those precursors, like she mentioned turn taking, imitation, joint attention, all of these functional play skills. All of these are very important predictors of a child's language abilities. Next slide. Is there medication he needs to take? So there's no FDA-approved medication for the core symptoms of autism, but there are some for related symptoms like ADHD, and Risperdal, aripiprazole are FDA-approved for the indication of irritability and autism, but they are not effective for the core symptoms or other comorbidities. Next slide. Does he need an MRI or EEG? So consider an MRI in children with acute regression, microcephaly, midline facial deficits, neurocutaneous lesions, or abnormalities on neurological exam. Isolated stable macrocephaly is not an indication for an MRI. So today, I know this kiddo was not quite macrocephalic, who's 98th percentile, but he's a kid that I would just keep an eye on and monitor. Consider an EEG in children with a history of seizures, acute regression, unexplained behavioral changes, or suspicion of subclinical seizures. Screening EEGs on all children with ASD are not recommended. Next slide. What about complementary and alternative medications and therapies? So the National Center for Complementary and Integrative Health is a wonderful resource. So you can kind of go to their website. The resources at the very bottom, ASAP, the Association for Science and Autism Treatment, is also another great resource for you guys to look at kind of the new kind of CAMs that are coming out and that families will be asking you about. Next slide. Are there special diets? So many of these treatments do not have scientific support for a widespread recommendation for a specific diet. Families will come into me and they'll ask me about this new diet that came out that I haven't even read about. So sometimes I have to do my own research kind of after the visit, but there is no specific diet that is recommended for the treatment of autism. Next slide. What are the chances his younger brother will have autism? So among identical twins, the identical twin will be affected about 60 to 90% of the time. And then for siblings, there's about a 20% chance of having a second child who is also affected with autism. I think I have autism. What do you think? Okay, so I hear this a lot now. So I never make a comment, right, on a parent and how they're presenting. They'll even ask me, like, do I give good eye contact? Please try to not answer that. I usually just refer them. I say, if you're curious and you want to learn more, I recommend that you see an adult neuropsychologist who can kind of help you better understand, yourself. So next slide. How long have you been doing this? What is your experience with autism? So everybody's answer to this is going to be very different. I have received this question before, and you just kind of have to go with the flow and answer it. So be prepared in case this does come up. Next slide. All right, key points. So just remember, parents, never forget the feedback session. Take your time and practice, right? It's not going to be perfect every time. Try to use more strength-based language and meet the family where they are at. Next slide. My references, and then I had some just resources at the end for everybody if they're interested. So we can add those to the website too, Lizzie. I think some of them are already on there. So, yep.
Perfect.
Okay,
Yes,
I know we're long.
Thanks, Amy. We'll make sure that those resources at the end are added to the session overview page on our platform. So thank you so much. We are going to come back again on July 11th, 12:30 to 1:45 Mountain Time. The topic is early interventions and educational strategies for supporting autistic children. So somewhat teed up by some of this today, presented again by Amy and perhaps Elena. Well, a little TBD on that one. So thank you so much, panelists, for preparing for July 11th, and we look forward to seeing all of you then. Thank you. Bye.